And that's part of what we're going to be discussing this morning. So today, we're going to begin the meeting with a discussion on leadership and governance for human resources for health. This panel will be led by my friend and colleague, Professor Elsie. She will be joined by a very, very distinguished panel led by the president of the World Medical Association, Dr. Jacqueline Kitulu from Kenya. Dr. Kitulu is also a past president of the Kenya Medical Association, and she holds very many other leadership positions on the African continent, and she's a distinguished leader in health. We'll also have Mr. Asajid Samuel, who is a lead executive officer for human resources for health development and improvement at the Ministry of Health in this country, in Ethiopia. And we'll also have Professor Charles Prober, who is a professor of pediatrics, but also the Senior Associate Vice Provost for Health Education at Stanford University. We'll also have Professor James Avoka Asamani, who is from the World Health Organization and from the Health Workforce Team Leader for the African region at the WHO Afro office. We have also Rihanna Nusema, who is a medical student, but she's the president of the Ethiopian Medical Students Association, who will be participating in this dialogue. Before I hand over to Elsie, I'll just make a few comments about leadership. So there are many deans who are attending this meeting. As it was pointed out a couple of days ago, none of those deans, and I looked around the room when this question was asked, none of those deans went through a leadership preparation process or a leadership training before they got into office. In many of our places, as we're going to see in the next panel conversation, deans are either elected or appointed in a process that does not take into consideration our ability to lead. But it uses other considerations. Either I'm the senior most guy in the school, or I'm the most popular guy, and so on. But it doesn't take into consideration my ability to lead a faculty. And so when COMSA was formed, we recognized this immediately, because none of us who were part of the originating of this consortium had gone through leadership training before we became deans. And we recognized that there were certain competencies that were necessary for somebody to lead a medical school. And as a result of that, then, one of the key components of COMSA was the Leadership and Professional Development Committee, which was formed right from the outset. And our mandate in that committee was to establish a leadership academy where, going forward, the new deans who are going to be appointed in the medical schools on this continent would have an opportunity to be trained in leadership, in addition to their professional qualifications. And so we initiated this program in collaboration with many of our partners. And in the first cohort of this leadership training, we selected 39 deans to go through a one-year fellowship, at the end of which we would hope that they would acquire certain leadership competencies that would benefit the institutions that they are leading. The mentorship is not only from Africa, but it's also with our global partners. And there is a curriculum that is blended. So we have a virtual component where there are certain self-paced modules in leadership, gender and sexual and reproductive health, and quality improvement. So all of those who have been enrolled in this program will have a quality improvement project as part of the deliverables. There are several interactive sessions, and each of the deans who are selected to participate in this program have a mentor. And today, this morning at the breakfast, we had those meetings between mentors and mentees who are going through this program. And then they also have a research project that is supervised. The quality improvement project is supervised to make sure that the competencies that we hope will be instilled in the leaders we have selected would be achieved. As part of this Leadership Academy, we have a component called the Women in Leadership component. And this came out of the realization that we looked at the composition of the deans of medical schools in Africa and realized that more than 80%, probably more than 85% at that time were men. And looking at the senior leadership in medical schools in Africa, the vast majority of people in senior leadership are men. And we think, based on global trends, based on the things that we do, that this is a problem. And so, to start addressing that problem, firstly, we selected the female deans within the cohort and had a special program for them, where we had one-on-one mentorship, personalized guidance and coaching by women former deans for women. And there are certain themed live sessions which are interactive, and we have women in leadership focused live sessions led by experienced mentors. So this is going on. Our goal going forward is that we are going to be going a notch lower than the deans and identifying future leaders within our medical schools and giving them the skills and attitudes and knowledge that is required for them to be available when the next deans are being selected. And so I will conclude. I will conclude by. I'm sorry. There we go. Thank you. Yeah. I'll conclude by inviting you all to participate in the social media platforms that we have here. But I want to hand over now to my colleague, Dr. Elsie Chigude, to take over the session. Thank you very much.
Thank you. Thank you, Professor Alkoe. Good morning, everyone. It's good to have you with us this morning. Thank you for keeping time. And those who are early, you know that early birds, I hope you collected a worm or something better than a worm. But it's really great to be with you this morning. And it's my pleasure to moderate this morning session with this distinguished panel that has been introduced. As you've heard, my name is Elsie Chigulimarade. I'm from Uganda. And I remember a long time back when I was appointed a head of department in the Department of Radiology. I'm a radiologist. I went to the dean and asked for the terms of reference. And he told me there were none, and he said, you go and do what you have to do. And I actually went and did what I had to do. I don't know whether I did it well, but I managed somehow. And later, it was later that I was able to do some leadership training. So it's really important. It's good to see that COMSA has taken this on and is really training the leaders. So as you heard, our session is on leadership and governance for human resources for health. And since Monday, we've heard that Africa has a shortage of health workers. And it has been reported by WHO that 36 of the 47 countries that have a critical shortage of health workforce are in Africa. And that by 2030, we'll have a shortage in Africa of 6.1 million health workers. That's of the 11 million for the whole world. So the shortage is not only here, it's global. But our shortage is compounded by other challenges. We have variations in training standards, curricular accreditation, and regulation across countries, as you heard many people say. While competence-based education reforms are being promoted and some work has been done by WHO Afro, their implementation is constrained by weak leadership and governance for human resources for health. So we know that we have a challenge, but we have to face it and handle it. So therefore we need to strengthen workforce leadership, planning, and harmonization if we are to build strong, resilient health systems and eventually improve the health outcomes of our population. Because as health workers, that's what we are here for. So this session is going to address some of these issues. We'll talk about leadership and governance gaps. We'll talk about the implications for health workforce shortages in our region, how we can strengthen national and regional human resources for health leadership, and also the roles of partnerships in advancing African ownership and sustainable HRH reforms. So I'm excited to have these distinguished members of the panel to address these issues. And we know that we don't have a lot of time, but they are all going to give us their perspectives, and we hope we'll have some time for you to have some questions and responses. I would like to begin with my colleague and friend, and also we are so proud of you, Jackie, because you represent Africa on the global aspect, as well as African women leaders in the global space, so we are really proud of you. Considering the global versus local standards, how can global professional standards championed by WMA be adapted to support context-specific competence-based training across diverse African health systems without reinforcing inequities, which we know the gaps are really wide? Over to you, Jackie.
Thank you, Elsie, and it's a real pleasure to be here. So going to your question, really, I'd like to begin by challenging the premise of the question. Because too often we are hearing global standards versus local context versus local realities. It's as though adapting to context means lowering standards. So it's a false dichotomy. As an African and as president of the World Medical Association, I believe African physicians and African patients deserve the same high standards of care as anyone else in the world. So I'll answer your question in 3 points. First, what does WMA's mission is? It's to uphold universal standards of medical ethics, professionalism, and patient safety, physician autonomy, and quality of care. These principles are universal because patients everywhere deserve them. 2, While the standards are universal, the way we achieve them should reflect local realities. African medical schools must produce graduates who meet internationally recognized competencies while being equipped to address Africa's disease burden and health system needs. And third, equity is not achieved by lowering the bar. One has called it poor medicine for poor people. If resources are limited, the answer is investment in medical education, in faculty, research, accreditation, and not reduced expectations. So Africa should not simply adopt global standards. Africa should shape those standards. Africa does not need different standards. Africa deserves the same standards and should be helping to define what those standards are. Thank you.
Thank you very much, Jackie. And so you know why she's representing us at that level. She's articulating what is good for us and is important for us to uphold our standards. So from global, we will go on to regional, and we'll go on to James from WHO Afro. And we know that you are involved in policy and ensuring that these policies are implemented in our region. So WHO Afro has promoted competence-based education reforms. What are the biggest barriers countries face in implementation, and how can they be practically overcome?
Good morning. Good morning. Thank you, and it's a pleasure to really join this discussion because this is a topic that is very dear to WHO's mission, but also personally, it's a topic that is very dear to my heart. So, in Africa, I think most countries have embraced the idea that time-based, content-heavy education for health professionals is no longer addressing what is required on the ground. What is required on the ground are medical graduates who finish and they are ready to practice. They are competent. So the issue of competency-based education is not really new anymore. And in many contexts, attempts have already been made to do it. But I would say that the main challenge for Africa is not the design of competency-based curricula. The challenge is how to implement it at scale. Why do I say this? In many contexts, what we have seen as a main challenge is that the curriculum is designed, well-intentioned, by a few very brilliant people, but it remains document and not used to transform the system. So what is actually required is to move beyond seeing competency-based education as an institution thing, as an education sector alone agenda for reform, but to move that into a system-level reform. It requires investment in the capacity of the educators themselves, in the clinical training platforms, in even the approach to assessment, and to some extent, infrastructure and equipment all need some kind of upgrade or reform. And so what we see across Africa now as the main challenge to implementing the competency-based education agenda that we are championing is actually how to galvanize political support and the right level of investment in competency-based education for health professionals. So it is not just getting the will of the educators. Somehow this week we are gathered here discussing very important topics, but we are preaching to ourselves who are already converted. Where are the people from Ministry of Education, from Ministry of Finance, who need to allocate budget to get some of these competency-based education reforms implemented and become real? So for us, the main challenge is really to take this to the broader level of system reform for the health system and for the education sector, not just a reform needed in medical schools. So we are seeing that challenge now as something we need to lift it beyond technical people who understand what to do to the non-technical people who hold the power of decision-making to make the decision to change. So for WHO, what we are doing now is to engage regulators to pick the competency-based curricula that has been designed with collaboration across Africa to see how they can reflect that in their national reference curricula. The idea is not to have one uniform curriculum across Africa, but is to have curriculum that reflects African realities, but also can lead to some form of harmonization, that you know that there's a minimum content, there's a minimum capacity that every doctor trained in Africa would have. So we are pushing for that level of decision making, and then the rest of it, when the resources are released, the rest of it, including development of the tutors or the trainers themselves, the clinical platforms, among others, can be addressed as a consequence of having the resources, the political commitment from political leaders.
Thank you very much, James. And it's really great to see how much work WHO actually is put into this, and we are really grateful. And the interactions and also calling up upon all of us to get involved in the work that is being done is appreciated. And what I hear is advocacy. As leaders in health profession, education, health workforce development, we need the ability to advocate for what we need moving forward. Because it's useless to have all these good policies on paper and we are unable to implement them. And without the politicians that hold the power and the finances, it will not be easy for us to move the agenda. So one of the things that we have to learn as leaders is to advocate for what we want to do. So thank you so much. So we go from regional and then we go to national. And we are pleased to have Samuel from the Ministry of Health leading the health workforce development in Ethiopia. And would like to get from your perspectives working in Ethiopia in health workforce, how can countries strengthen leadership and governance to address persistent health workforce shortages, particularly in underserved regions, giving your experience in Ethiopia? Over to you.
Yeah, good morning. Thank you, Elsie. I think I would like to start with one of the comments that we agree. So workforce is, as most of we say, one of the important pillars of our healthcare system. But the question comes here is, are we really investing with a significantly to improve workforce in our context is the challenge. So when we go to every country, in every corner of the continent, the investment we are doing to improve the workforce capacity retention is a challenge. So with these all issues, we are dealing with different kinds of issues. So with this, Ethiopia has made actually lots of investments to improve workforce capacity in our country. So one of the issues I can speak from our experiences, strengthening leadership capacities at all levels is very important to improve workforce, especially in underserved regions. So over the past 2 decades as a country, we have actually implemented different kinds of strategic directions and initiatives to improve workforce capacities in our country. So this brings us, to improve workforce planning, retention, as well as production, especially considering our national priorities and the health sector, as well as the needs of our society. So for that, one of the key and a very important lesson from Ethiopia's experiences commitment from the government is very important. But not only commitment, I think there has to be institutional coordination. There is commitment from government, but if we don't have institutional coordination, we will not move far as we want. So Ethiopia expanded its workforce through different kinds of initiatives we have implemented, like the flooding strategies, different kinds of initiatives to improve the number of workforce in our country, especially some of the large-scale training initiatives like the flooding, specifically, focusing on improving the residency matching training programs, and others can be mentioned as experience, but not only, improving the number of workforce in our country through different kinds of investment, but as a country, we have also invested simultaneously in deployment systems, because we are producing workforce, but unless we have a system to absorb what we are producing, that will be another challenge. So we have simultaneously invested in improving the deployment system to ensure we have equitable, fair distribution of workforce across the healthcare system. So in addition to that, leadership at national and subnational levels are very important. So we have actually implemented different kinds of methods to support, improve, especially the workforce planning, the workforce management and rotation strategies across the different tiers of the healthcare system, especially in areas where we need more number of workforce, especially in underserved areas. But however, there are challenges remain as most of the African nations, especially one of the challenge we are facing is retaining workforce, quality of medical education is there. But as a country, actually, we have invested and implemented different kinds of methods and strategies to improve retention of workforce as well as quality of education. So one of the things we have done in the past was improving faculty development. We have introduced licensure examination and supporting medical schools in different kinds of methods is one of the interventions we have made in the past. So this underscores that leadership is not only about scaling numbers. Leadership has to be ensuring quality, sustainability, and the performance of workforce across the level. So this is the experience we have in our country. Thank you.
Thank you very much. And you can see the flow. We need the policies, but we need to implement them. And what we hear from Samuel is that as they increase the numbers, they need to look at the quality. But then the ministries have to plan. Because right now in Africa, we have a challenge that we have many health workers that are actually not employed. So we have plenty, but we are starving. So living in a land of plenty with starvation is really unacceptable. So our ministries of health need to plan and plan with the training institutions. So thank you so much, Samuel. We go on to Rihanna. Rihanna, you are a very important member of this panel because you represent our future. As a student, in a few years, you will be the one practicing and leading the health workforce. Many of us may not be practicing anymore. So we are really glad to hear from your perspective. So as a student, what do you think are the current gaps in our training generally as we prepare you for practice and for leadership in human resources for health? Over to you, Rihanna.
Thank you very much. Good morning. So as it already been mentioned, the curriculum that we are striving to improve and enhance right now, we are the owners of it, and that is literally the future of African medical education. So yeah. So when I'm talking about the curriculum, I'm specifically talking about the curriculum that is being implemented and that's being delivered to us, the students, rather than the curriculum that's on the textbooks and that is in the formal documents. So back to my question. Currently, most of the medical education in Africa is largely built on hospital-based and specialist-driven care. While most of young graduates spend most of their early career in resource-constrained and generalist settings, often alone without any immediate backup from specialists. So the key gaps that I want to emphasize on are: first, there is a curriculum to context mismatch. When I say this, the current training that we have emphasizes mostly on tertiary level pathologies and technology-dependent diagnostics, but mostly our graduates are deployed to health centers where the districts and district hospitals where the reality is limited, where the reality reflects limited equipment, unreliable supply chains, and also fluctuating patient volume. So students learn to manage diseases in theory more than they do in reality. So this is one of the gaps that I see in the curriculum. And the second one that I would like to emphasize on is underexposure to non-clinical competencies. What I mean by this is leadership, health systems thinking, quality improvement, and data for decision making, and also emergency and disaster response. These are the immediate skills undergraduates are going to need when they are deployed to under-equipped and also under-resourced environments, but they are not actually integrated into our curriculum. So this is something that we need to work on. And there is also a weak pre-hospital and emergency care exposure. When I say this, most curricula are hospital-centric and students are given little to non-structured exposure to pre-hospital systems, referral pathways, or first-hour care, despite that's where most of the diseases occur, especially in maternal and child health and also in trauma setups. So that's also something that we need to talk about. And the other one is there is simulation. There is a gap between the simulation and the practical readiness. When we say this, simulation-based learning is integrated into most of our curriculum, but wherever it exists, it is underfunded or inconsistently integrated into the curriculum. So students often graduate having learned about the curriculum in theory more than they do in practice. So, and at least not to the fullest. So those are the things that I want to mention when it comes to the gaps in the curriculum. So I would like to conclude my point by saying the gap is not that students lack the skills, but the curriculum that we have right now doesn't actually reflect the situations or the environments our graduates are going to work in. And also closing that gap means shifting the training into, at least not entirely, but at least some of the training into real healthcare setups where like environments such as pre-hospital referral and also simulation-based learning are consistently integrated into our curriculum. Thank you very much.
Thank you, Rihanna. I wonder how many of us include students. Thank you. Yeah, she deserves a clap. I wonder how many of us include students when we are planning our curriculum. And you can hear where the gaps are. We train them at tertiary hospitals and we expect them to go immediately and work in primary health care. And we have not prepared them for working in those underserved areas with minimal equipment, with many challenges that do not exist at the tertiary hospitals. Thank you, Rihanna, for highlighting those challenges. And you know, as medical educators, we always invite external examiners to our exams. So it's really good to have somebody looking in from the outside to see what we are doing. So we are really pleased to have Charles on our panel, because he's one of us in a way, but also he's from another part of the world that he can look in and see what we are doing. So Charles, I know that over the past 2 decades, you've published several perspectives and commentaries in international journals, some of which I've read and I've found very inspiring. I'd like you to highlight some of the things that you see that COMSA could contribute to the global perspective on medical education, specifically looking at collaboration. And I know that you have written a lot about collaboration in those in those articles. Please give us your reflections on that.
Thank you, Elsie. And just to assure you, I have a timer, which I'll put on, and which I always need. And the reason I asked to be able to speak after all of our colleagues was that my principal message is going to go off script to begin with, before I answer actually the question about collaboration. And I want to start by thanking the organizers of this meeting, my friends and colleagues that I've known for a very long period of time, for inviting me to participate. I truly am honored. And I'm inspired and I'm jealous at the same time. So why am I inspired? Well, I'm inspired because my first introduction professionally to your continent was in Rwanda, and it was through an invitation by my friend and colleague, and known to many of you, Paul Farmer, who, as you know, had established within Rwanda an opportunity to build a university which has the best, most descriptive name of any university, I believe, in the world, the University of Global Health Equity. And when Paul reached out with the then CEO of Partners in Health, Gary Gottlieb, and asked for participation, I was deeply thrilled, honored, and it is actually the most professionally rewarding relationship I've had in my medical career. My inspiration continued after the initiation and continues, sadly, after Paul's untimely death, when I had the opportunity to work with people like Ababe Bikele, who is extraordinary in every way, and in helping to organize this consortium of medical schools. It's incredible. And Abebe, joined by Phil Cotton and the amazing faculty and staff that they've created at UGHE, again, is an inspiration not only to me, but to, I think there's maybe 100 colleagues from my university, Stanford University, who have chosen to come to UGHE to learn more than to contribute. You heard from one of those individuals, Kara, the other day when she spoke about surgical training and how that is globalized. I'm very proud of Kara. I met her when she was a first-year medical student, the source of so much pride to many of us when our mentees become ultimately our mentors. But I'm jealous. So why am I jealous? I'm jealous because you are doing something in Africa which cannot be done in North America. I'm actually Canadian. I like to put I'm Canadian out front, especially lately, but I do live in the United States. I also put out Canadian because I've concluded from the 72 hours and the many years that I've interacted with Africa that, and this is a compliment to Canadians, we're like Africans. We are collaborative people. We work together to build something that cannot be built except through collaboration. So my jealousy is that when I was Dean of Education at Stanford for a decade before I developed my center, I wanted to build collaboration, certainly within Stanford, certainly across the state of California, across the United States, and even more broadly, and I failed. And I failed sometimes even, please don't repeat this, to get collaboration with members of the same course in the medical school, let alone all the courses across the medical school. And I failed in terms of getting medical schools to come together and practice the principle of a crowd is more effective at generating the right answers and the product you're seeking than an individual. So I built a small consortium. It went on for a while around a particular entity, but we have not had a consortium of medical schools of substance, in my opinion, in the United States. And you started 16 months ago, March of 2020, 16 months ago, and you've created a collaboration, a consortium of 191 medical schools. It's mind-boggling. And so that's why I'm jealous. My life's dream in medical education was to get people to work together, and I've had some success, but not at scale. To the question, Elsie gave me twice the time because I was only going to speak once. To the question about what I've written and opined about. I mean, if you're not the expert, you write commentaries and perspectives, and then you pretend to be the expert. And I've had the opportunity to publish perspectives directly related to medical education, from Lecture Halls Without Lectures in the New England Journal to the more recent stuff, which is relevant. And the more recent stuff is Tao Li and I wrote a paper in Academic Medicine about 8 years ago, which talked about an ecosystem of collaboration to advance medical education, primarily focused on medical schools, not health professionals overall, and primarily focused in the United States, Canada to an extent, not the world. And the principles of that I won't iterate, but it is available still in the journals, but I'll pass on that. But more recently, actually very recently, actually last week, another editorial, an invited commentary to Academic Medicine, I published again with Tao and with David Achorena, who's an amazing guy if you don't know him. David was the Director General Executive Director of the WHO Academy in Lyon. And before that, he was the Director of UNESCO Lifelong Learning. So he knows a lot about learning. And he joined us in writing, and the title of the commentary is the description of what we encourage and what you're already doing. So the title is enough. Towards a Global Ecosystem for Health Professional Education, Harnessing Open Educational Resources, Sharing's not in the title, Generative AI with Shared Governance. And each of those particular elements, OER, AI, governance, we discuss in the paper about how we believe it can happen at a global scale and across all health professionals. This is a dream in my mind in medical education and health professional education that was not attainable until the last decade, but even more accelerated over the last year, and maybe you could say now even recent days. So it is something which is accomplishable. It's something which requires collaboration, and in my opinion, collaboration runs through the blood of everybody in this room. So Alain was saying that I am deeply optimistic about what you are pursuing together. I recognize in this room and beyond, the people that couldn't attend this meeting because it's sold out, I guess, you're beyond. You are talented, you are enthusiastic, you are dedicated, you are selfless people who hold in your hearts that spirit of collaboration, mutual trust, and respect, with a commitment. And I've heard it from so many conversations I've had over the meeting and the speakers as well, with a commitment to serve all of those you touch, your colleagues, your students, your communities, and most importantly, the 1.58, is what Wikipedia says now, people that live in Africa and depend upon you for their wellness and their lives. I am so pleased to be here. Elsie, thank you.
Thank you very much. Yeah, thank you so much, Charles. That's very encouraging. So to hear all those compliments from you, we are really on the right track. And many times we tend to evaluate ourselves and look at the negatives. But you see that already COMSA has done so much in such a short time, and that's really wonderful to hear that other people are also recognizing that's being done by COMSA. And imagine the collaboration for the leadership program. That would not have happened if we were just working as individual institutions. So thank you for those encouraging words. And collaboration is really important. We started a bit late, so we will maybe take 10 more minutes of probably some other time. I don't know how it will be done by the organizers, but we'll try as much as possible to finish by 10 past. So the second round of questions will be very brief, and I would like still to go back to Jackie and find out what do you think the global world, including the global professional associations and in other countries, could do to help us with the migration issues, because this is still a big challenge with us in Africa.
Thank you, Elsie. I think health worker migration is, I think it's one of the defining ethical challenges of our time, because it involves the rights of the individual, but also our collective responsibility to provide equitable, access to health care. But that said, number one, physicians have a right to migrate. So we should never blame individual doctors for seeking better opportunities for themselves and their families. Migration is often a consequence of systemic challenges rather than, individual choices. However, this is the responsibility part. High-income countries have ethical responsibilities in how they recruit. Because countries facing workforce shortages should invest in training sufficient numbers of their own. Those are the high-income countries. They should be investing in training their own and ensuring, therefore, that when they recruit internationally, they follow ethical principles. And these global partnerships should not be directed at weakening those that are already under pressure. So in that responsibility, then, even when they recruit, there should be a balance in terms of what is the return, what do they return to those countries. And I think WHO will probably talk a lot more on some of the thoughts they have around that process. But going back to our own African governments, they also have a responsibility, because then they should be, planning, training to retain, so that they should be looking at fair remuneration, safe working environments, career progression, continuous professional development, and respect for health professionals. So patriotism alone cannot retain a health workforce, because that's one of the things they told you, be patriotic. Patriotism does not feed your family as the health professional. We should be looking beyond that. The medical schools, and here we are at COMSA, are central to this solution, because medical schools are investing in tomorrow's workforce. Governments must ensure graduates have employment opportunities, specialist training pathways, and environments where they can flourish professionally. Our goal should move from brain drain to brain circulation, creating opportunities for collaboration, for research, exchange, and return. So the answer is not restricting movement. It's creating health systems where physicians choose to stay because they can build fulfilling careers while serving their communities. Thank you.
Thank you very much. And I can see that it all goes back to planning. And it really is calling on our governments to make sure that we plan for our health workforce. And we'll go back to James. We know that you are doing a lot of work at WHO Afro to support the improvement of health workforce data systems for better planning and deployment of the health workforce. Can you tell us about what you're doing and what the challenges are? The innovations that you are doing right now.
Thank you, Elsie. And I couldn't agree more with Jackie when she espoused very eloquently about the challenge of migration, and it's back to the issue of planning. So, in Africa, not only Africa, I think this is widespread. We're trying to address today's workforce challenges, which is in the 21st century, with data systems and planning tools that were meant for the 20th century. And so with that, we're starting first with the challenge of what we are using to plan. Why do I say this? For many, many decades, we've always known we have a problem with having adequate numbers, having the right levels of competencies. What have we done about it for many decades? A report that we published in May of this year is titled The State of Workforce in Africa 2026, Plan, Train, Retain. That report shows many things that is interesting and also pricks us what we need to do. Let me, for the context of speaking with predominantly doctors in the room, let me give you just 4 facts. First one, my colleague Champion mentioned yesterday that we have revised the projected shortage of health workers in Africa to 5.85 million. That means there's been an improvement in the stock. The stock has grown from 5.1 million to 5.72 million in the last 2 years. So ordinarily, it looked like good news. But the other side is that almost 1 million health workers who are trained are unemployed and they are on the streets looking for jobs. I am very sad to mention that it includes doctors. Unemployment rate of doctors is getting close to 20%, which is almost unheard of. Now, put that aside. If you look at even the doctors, we are growing the stock of doctors in Africa by about 2.7%. 2.7% per year on average in Africa. Recently, the stock of doctors in Africa is almost 450,000 doctors in Africa. If we add the unemployed, it could be a little bit more. But as of today, the shortage of doctors in Africa is 690,000 more are needed if we want to stand any chance to tackle the disease burden of Africa. Now, if you were to continue the way things are moving, 2.7% per year, given the disease burden changes, given population growth, the shortage is increasing each year by 2.8%. What it means is that our current planning systems, our current training models is only okay to keep the population receive the level of service from doctors the way it is today. We call it status quo planning. Well, that's what we've been doing. What is needed is to change the narrative of that paradox of where we are having unemployment alongside shortage, and doing so much only to keep the population receive the status quo service they are receiving now. To change that requires investment. And so in WHO, what we are doing with countries is to say, you know what, talking about ratios, counting how many doctors are there, how many nurses are there, is no longer enough. What is now needed is to move beyond that. If the business of health sector is to ensure the population is healthy, let's take a step back and ask, what are the health concerns of the population? What is the disease burden? What makes people sick, ill, die, or otherwise require health service? Let's take that and now come and ask, what services as a country can we provide to address these health concerns? Which health worker has the competencies to be able to do so? And then how many of those do we need now and in the future? Then we can put that together in our national budgets for the future and plan. If we need 100,000 more doctors in Ethiopia in 10 years, we put that in the budget today to train that 100,000 doctors for 10 years to come. Because if you need a doctor today, they should have been trained 7-8 years back, not those who will be taking them in school today. So that's the kind of planning we're helping countries to move towards, and that's why we are championing the program of plan, train, and retain. So there has to be a synchrony. You have to plan and put it in the budget. Where you have budget is a priority for the country. Being a priority is not about slogans, it's about putting it in the budget. That's why we see that you are really serious about what you're saying, that it's a priority. Then second is to train appropriately using competency-based approaches. And finally, is to retain them, that is, give them decent jobs, address their concerns, that they'll be happy to remain and work. Don't tie their hands and say legally you can't travel. Thank you.
Thank you very much. I think because of time, we are going to go ahead and allow you to interact with our panel. And if we have time, maybe we'll have some final reflections from our panel. Thank you so much, panelists. Those were very insightful perspectives. So We'll take 2 already here and 2 from this side. Yeah, 2 over there. Please pass them the mics and they give us their contributions or questions. Please introduce yourself and make your questions short and precise because we need to hear from as many people as possible. Right here. Please go ahead.
Good morning to everyone, the panelists. My name is Dr. Wale Abdullahi from Banaadir University, Somalia. In back home, we have challenges. And one of the main challenges is the specialists and the doctors. They don't go to the rural areas or outside of the capital. So this goes to all of you. How can we convince them to go and work in the rural areas? And you know, the patients, they used to come at the capital in order to seek medical advices. So the second question is the leadership. As an MOH, the Minister of Health in all those countries, in African countries, how can they take this rule to our doctors and specialists? Thank you so much.
Thank you. The Dean from Moi. We have to be gender sensitive, so we'll take a gentleman and a lady, and then on the other side, the gentleman and lady also.
Thank you very much. To give the floor, I'm Professor Alumeti Munyali. I'm the Dean at DRC University in East of Congo, Bukavu. I take the floor to say that I'm listening what the students say, and I can say to the Dean, we are Dean because we had the student. In DRC, we had the same problem. The student go to the hospital, but they don't had some possibility to integrate the system. We know in the curricula, we focus the program for the hospital, but we don't have some possibility to the student to integrate the system in the many hospitals. So, what we do in DRC we added a program, a course, who is a situation of integration, situation d'intégration. This course is adapted to all year of academic. And now the student is easily to practice in the hospital. I think that it can be a good opportunity to put this course in all years training for the student. Thank you.
Thank you. May we have the Dean from Moi? She's right there. Please give her the mic.
Thank you, moderator, for this opportunity and the panelists for such stimulating discussion, allowing us to really understand the great work that is going on globally, regionally, and in Ethiopia, but also allowing us to share some of the challenges that we see. And one that has persisted for a long time is we have specialist and subspecialist training without optimum support in terms of salary, scholarship, and the kind of support that a doctor needs, especially when they have to train full-time every day, sometimes even for extended hours and even on weekends. In my country, Kenya, we still have in the public sector residents and clinical fellows paying fees and not being remunerated. So what then happens is they're struggling to locum and get some resources to support themselves and their young families, and at the same time trying to give us all the time we require for them to learn. So that is still a big challenge. It limits the number of specialists coming in to train, but also their attention is divided when it comes to the focus in their areas of skills development. The second one is on brain circulation. We actually now see high-income countries come to us directly. They take a flight to Nairobi, they'll take an extra flight to Eldoret, where I come from in the western side of Kenya, and talk about how do we prepare your senior class to come to our country. And for me, I always have the same ethical dilemma that Dr. Kitulu mentioned. How do we actually allow a country to struggle to train a doctor for 6 years? I don't have resources. My faculty are working a lot, and someone has the audacity, and I'm using the word audacity, to come and stand at the finish line and buy me lunch to be able to hand over the young Kenyans to their high-income country to go and work. Governments support us to have G2G arrangements, government-to-government arrangements, where there has to be investments in my school, tangible investments in infrastructure, in human resource, in equipment, in consumables. Let's prepare them together, and then we share the circulation. Thank you.
Thank you very much. The other side at the back. So we'll have to, I'm sorry, we shall continue the discussion during tea time. We have limited time. Yes, please. And then.
Thank you. My name is Sojara Sande from Gulu University in Uganda. I'm coming from the context of Paul Farmer, who came and immersed himself in Rwanda. Paul Farmer was my good friend, and I met with him. When I look through what he has done, it was a kind of leadership that he found equitable environment in Rwanda. My question to the global community: how do we build an equitable collaboration with African university? And my second question to the leading African university: how do we build faculties strengthening across board in the rural areas, so that I from Gulu University can benefit from University of Cape Town when I am working at Gulu University without necessarily traveling to South Africa? Thank you.
Okay, thank you very much. The last comment from somebody there at the back, and then we'll close. We'll continue the discussion later. We still have the whole day together.
Thank you, Elsie. I'm Joel Okulo, the President of the Association of Medical Councils of Africa. First of all, I would like to appreciate the invitation to come and attend this meeting. And I do appreciate the work that COMSA has done so far. I would also like to appreciate my brother, Professor James, who invited us to Brazzaville to design the CBE curriculum that we are talking about. CBE is not a new phenomenon. It's something that has existed for some years, but maybe many people don't realize that they're in one way or another implementing it. I say this because I think if we want a success for CBE, it should start much earlier on in the education system. In fact, as low down as the secondary schools. But having said that, the other day when we asked how many of the deans have seen the documents that have been prepared by WHO Afro, we only saw a handful of hands up. This therefore means that if we are not careful, the good documents that we have produced is going to remain on the shelf. So I would like to suggest the following. Number one, let's have a deliberate attempt to disseminate this document. I know that is easier said than done because it can be quite expensive, but that's the way that we need to go. Secondly, CBE may be new to many of the deans, and I would like to suggest that there should be a training of trainers so that they can be champions, they can be leaders in implementing CBE. That means looking at what it is saying, and importantly, how to implement it, and how to examine, how to assess the students who have gone through the system. This may be easier said than done, but I think those are the ways that we need to go. Lastly, I would like to repeat the commitment of the Association of Medical Councils of Africa to work side by side with you as we implement this curriculum, and we give you support in the sense that we are able to cover almost all the medical schools in Africa together with COMSA. Thank you.
Much. So we'll go on to our panelists and give them 1 minute each to just give us their reflections, and then we'll close the session. We'll begin with you, Jackie.
So thank you for that stimulating discussion, and there's a lot more I think we shall have out there in the coffee break. So for my one thought that I'll leave with you today is that Africa does not need lower standards. It needs greater investment, stronger leadership, genuine partnerships. I believe our role is not simply to adopt global standards, and Africa should never aspire to those different standards. We should aspire to help set the standards by which the world measures excellence in medicine.
Thank you. James, your last reflections?
Thank you. My last reflection is that Africa is facing a paradox, and that paradox can only be solved by us here in Africa. Let's invest in health workers, plan how many workers and of what kind your country needs, and educators train them to the best quality possible, and let's advocate for them to be employed and retained in Africa. When they have to be in rural area, let's apply the rule of compensating difference. If your working conditions are worse off compared to your peers, you must be compensated in other ways for that worse off working condition. Thank you.
Thank you very much. Samuel?
Thank you. I can't agree more with what James said. I think one of the critical issues as a continent is we need to seriously invest in our workforce. So we are saying we need more number of workforce, but we are not deploying. So I think we need to see how we can create balance between our needs and the production capacity. That's one of the things I would like to present. The other thing is we want to send our healthcare professionals to underserved areas in rural areas. That's the challenge all we are facing. But the question comes is, what do healthcare professionals need in those places is, the very critical issue. So we need to see how we can, retain professionals to work in this area. Especially, there has to be, conducive work environment. The career progression has to be there. The communication, everything has to be there. So we need to see how we can implement those things to support these professionals. Is very important, so that we can retain the professionals to work in unserved areas. The last thing in CBE, competence-based education. When we are talking about harmonizing training standards, we are not talking about making training standards to be uniform. The ultimate aim is to have consistency among the competency of the graduates. So in order to do that, it requires a system-wide improvement. It's not only investing in harmonizing curriculum, but we need to also invest in infrastructure, faculty, and other issues. This is a way to really implement CBE in our healthcare system. Thank you.
Thank you very much. Rihanna, please.
Right. I agree with everything that was mentioned earlier, but the one thing that I would like to mention is, as much as we need the capacity building and investing in the health workforce, we also need to have a structured pipeline between student bodies to policy process. What I mean by this is organizations such as IFMSA or International Federation of Medical Students Association already train students on policy development and also advocacy and other related topics. So the thing that we have to do right now is to create a link or to create a bridge between that advocacy or those policies so that the policies developed by the students can directly feed into the ministry's policy making process, so that instead of existing in parallel, they start to exist as one whole. And ultimately, students or young professionals would be taken as more of as contributors rather than beneficiaries of this whole healthcare system. And in order to make this a reality, we need a real representation in decision-making tables and also policy reform areas, as well as curriculum development rooms. And in order to be able to do this, Ministry of Health and also curriculum developing bodies need to work with already existing medical students association bodies. And I would like to take this opportunity to thank the Ministry of Health of Ethiopia as well as Ethiopia Medical Association for the continued effort to integrate students into dialogues and conversations that are taking place with regards to curriculum and anything that concerns medical students. So that should be how the way forward. That's how the way forward should be. Thank you very much.
Thank you.
So that's
Yes,
such an easy question about how to solve the global disparities in health education and healthcare, and so that the world is treated in an equitable fashion wherever we turn. Again, I spoke about Paul Farmer at the beginning of this conversation, and as many of you know, he lived by the principle that the quality of healthcare that was available in one part of the world must be made available all over the world. And he was mocked at the beginning, or certainly not believed, that you could bring, for example, HIV treatment to the African continent. He worked hard with many, many people, but in collaboration with international governments, NGOs, academic medical centers, local resources. And that, in my belief, that's what it requires. The questions raised all sorts of problems with regards to medical education and not getting community practitioners and all of that stuff. That exists even in developed countries, which is crazy. The misdistribution of funds. But I think that the major question, obviously, is how do you fund what needs to be done at such an enormous scale that's been described by all the previous speakers who know what they're talking about. And again, I believe, and I tend to be optimistic about everything and mostly naive about solutions, that until the global community recognizes that health care is not a privilege, it's a necessary quality of all people who live in the world. Sadly, that statement was debated in the last presidential debate, where they disagreed about whether that was right or not, which obviously it is right. So it's the solution is clearly not present, but I think with NGOs and supports of international governments and the lobbying that you guys will so effectively do on behalf of the population of Africa is a path forward. But it's trite for me to say, there you have it. Thank you for allowing me to be here.
Thank you. Thank you very much. What I hear is that we need to invest in our health workforce. We need to accelerate competence-based medical education and harmonize standards. We need to strengthen evidence-informed workforce planning and Africa-led partnerships and shared accountability, and we need to commit to training and empowering our health workforce. Please join me to thank our panelists for their contributions. And thank you so much for being here. It's been a pleasure moderating this session. Thank you.
Thank you, Prof. There is another plenary session before we go into the break, so please stay in your seats. Thank you.
የሚጠበቅበት ታካሚን ማከም ብቻ አይደለም።
You are really showing us the real brotherhood, the real Africa spirit.
ጎረቤት ጤነኛ ካልሆነ የኛም ጤና ዋስትና አይኖረውም።
ኢትዮጵያ ለሌሎች አፍሪካ ሀገራት የምታካፍለው ትልቁና ዋነኛው ነገር የሬዚደንሲ ፕሮግራማችን ነው።
የኢትዮጵያ የሬዚደንሲ ማቺንግ ፕሮግራም ከመጀመሩ በፊት በሀገራችን የስፔሻሊስት ሐኪሞች ቁጥር ከ1500 የሚበልጥ አልነበረም። በመሆኑም እንደ አውሮፓውያን አቆጣጠር በ2017 ፕሮግራሙ በሀገር አቀፍ ደረጃ የተጀመረው የስፔሻሊስት ሐኪሞችን ቁጥር ለማሳደግ በማለም ነው። በሂደት የማሰልጠን አቅም ሲያድግ ደግሞ ለአጎራባች ሀገራት ሐኪሞች እድል በማመቻቸት ተጠቃሚ እንዲሆኑ ተደርጓል።
በመንግስት ከ37 በላይ የሚሆኑ ዩኒቨርሲቲዎች ላይ የሕክምና ትምህርት መስጠት ተችሏል ማለት ነው። በግል ደግሞ ወደ 9 የሚሆኑ የጤና ትምህርት ተቋማት በተለይ ዩኒቨርሲቲዎችም።
Good morning again, everyone. So distinguished panelists, colleagues, students, and friends, thank you for joining us. I'm just waiting for the slides to come up on the system. Thank you very much. So I'll start with administrative announcements. This panel is going to be completely in English, so those that require translation to French, please do look for the colleagues that are handing out translations. We're here to discuss a very simple but difficult questions. Who pays to train African doctors? I think there was a lot of discussions in terms of the challenges. Sorry. Yes. So there's a lot of discussions in terms of the challenges that the health workforce faces. And I think the panel before us and also across the 3 days, there were a lot of discussions regarding the burden of disease. I think we've heard that Africa bears 25% of the global burden of disease, 3% of the health workforce, and the latest estimates from WHO estimate 5.85 gap. But in terms of the paradox, we also have 1 million unemployed health workforce. So the question is not only how we train more doctors, it is how we finance their training, their employment, their retention, and making sure communities benefit from the investment. So I'll try to provide some from literature in terms of how the different financing models are being carried out for medical education. But I'll use different stories to articulate how they're funded. The first story is about a football academy, and this is in light of the current World Cup that's ongoing. So imagine a small academy in Lagos. Coach sees a 9-year-old boy playing on a dusty field. He's talented, disciplined, and full of promise. So the academy takes him in. For 10 years, they train him, they buy his boots, feed him, pay for transport, treat his injuries, and give him coaches, discipline, and hope. The academy does not have enough resources, but they keep investing because they believe in him. Then he turns 18, a wealthy club sees him and says, "We want him." In football, we know what should happen. The club does not simply take the player. There's usually a transfer fee, training compensation, or at least recognition that someone invested in that talent. But imagine if the club said, "Thank you, we'll take him, we'll not pay the academy or invest in the next generation." Everyone would know that something is wrong. But in health, this happens all the time. African countries train doctors with public money. Government subsidize medical education. Families sacrifice. Public hospitals provide clinical training. Then the doctor is fully trained and the richer health system recruits them. No transfer fee, no compensation, no contribution to the training of next generation. So these are not just assumptions or theory. A human capital analysis that was conducted in 9 African countries that lost their resources to Australia, Canada, the UK, and the US represented a loss of 2.17 billion for the source countries and a gain of 4.55 billion for the recipient countries. This is the model of public financing. Public financing is essential for equity. It says that a student should not need wealth to come from a wealthy family to become a doctor. Across the African region, about 63% of health educations with known ownership are publicly owned. In many sub-Saharan African countries, medical schools are either tuition-free or charge less than $1,000 per year. But public financing is under pressure. If graduates migrate, the public investment may not return. But even before migration, our countries are facing limited fiscal space, debt servicing, wage bill caps, and competing priorities. So medical schools may want to expand, but budgets for faculty, lab, teaching hospitals, and supervisions do not grow with the same speed. So public financing protects fairness, but it raises a very hard question. Can government sustain this model when budgets are constrained and many graduates may still leave? The second story is about a water tanker. Imagine a neighborhood where the water system is weak. The pipes are old. Some days, water does not reach the families. Then a water tanker arrives. For that day, it's a blessing. It fills the tanks, helps the clinics, the schools, and helps families continue with life. But everyone knows a tanker is not a water system. If the tanker comes today and not tomorrow, the neighborhood is back in crisis. This is the risk of donor financing. Donor and philanthropy can bring fundamental resources quickly. It can support scholarship, faculty development, labs, specialist trainings. Regional centers of excellence, and we have great examples of this. The MEPI program have invested $130 million between 2010 and 2015. The African Centers of Excellence Initiative has mobilized more than $657 to training and supporting 80 regional centers of excellence. And the African Pediatric Fellowship has trained over 236 pediatric specialists. These are very important achievements. But the question is sustainability. A tanker can save lives, but it cannot replace pipes. A grant can transform a department, but it cannot replace a national financing system. A donor can support one cohort, but someone needs to think about the next one. So donor financing gives speed and innovation, but it raises a hard question. How do we make sure donor financing strengthens the system instead of becoming the system? The third and final story is about transport. Imagine in a city where public buses are not enough. The queue is long, students, workers, and patients are waiting. The city needs more buses, but budgets are limited and procurement is slow. Then private minibuses enter the road. They help. They create more seats. They respond to real demand. But now the fare matters. Those who can pay get on. Those who cannot pay remain behind. That is private medical education. Private schools can expand training capacity quickly, especially when public universities are full and government budgets are constrained. While private institutions account for 36% of identifiable health education institutions, their growth is striking. Private medical schools have grown 338% since 2010. So the private sector is becoming one of the main drivers of expansion. But when the student pays, the family carries the burden. Some sell land, some borrow, some never apply because of the cost. And if graduates carry the risks, they may avoid public service, rural postings, or lower paid specialties. There's also the quality question. Expansion without enough faculty, clinical training sites, and regulations can create risks. About 21% of African countries do not have formal accreditation systems. So private financing expands capacity, but it raises a hard question as well. How do we grow quickly without making medical education only for those who can afford it and without compromising quality? So we have three stories: the football academy, the water tanker, and the city bus. And we have three financing models. Public financing protects access, but is constrained by fiscal space, wage bill gaps, debt distress, and migration. Donor financing brings acceleration, but can be temporary if not absorbed into national systems. Private financing expands volume, but can exclude resource-limited students and stretch quality assurance. So the question today is not which model is perfect. None of them are. But what is the right mix? And which is why our esteemed panelists will help us look at this question from different lenses: a consultant, an educator, a funder, and an academic institution leader. With that, let me introduce our distinguished panel, and I'll ask them to come to the stage as we're introducing them. Our first panelist is Mr. Mwinga Tuita. Mawinga has spent his career in strategy, policy, and grant making, most recently at the Andrew Carnegie Foundations, formerly known as the Carnegie Corporation of New York, where he worked on the foundation's Africa grant making, including the long-running higher education portfolio. He's currently based in Nairobi, where he's currently consulting with the Rockefeller Foundation. Welcome. Our next panelist is Ms. Stella Itungu. Stella is the Chief Executive Officer of the College of Surgeons of East, Central, and Southern Africa, the largest surgical training institution in the region. She oversees the operations and strategic delivery of surgical education, workforce development programs across 24 countries in the region. Stella serves as a board member of the AO Alliance, chair of the High-Level Council on Global Surgery Foundation, and honorary member in surgery. Her expertise span global surgery, health education, strategic partnerships, regional integration, policy harmonization, and transformation program leadership. Welcome. Our next panelist is Ms. Melissa Morrison. Melissa leads the Health Workforce Portfolio as the Director of Programs at Elma Philanthropies, the service arm of the Elma Group Foundations. At Elma, Melissa develops and leads program strategies, identifies and connects changemakers to capital, and builds philanthropic relationships to advocate for increased coordinated investments to transform maternal and newborn child health across Africa. Welcome. And our last panelist is Prof. Philip Cotton. Prof. Philip, who's a citizen of both the UK and Rwanda, is the Vice Chancellor of the University of Global Health Equity. He previously provided leadership at the University of Rwanda, first as the Principal of the College of Medicine and Health Sciences, then as Vice Chancellor. Since leaving the University of Rwanda, he worked with the MasterCard Foundation on the Scholars Program and established a consulting company in Rwanda working in health and education. Welcome, Prof. So with that, let me move closer to my panel. Thank you very much. So I'm delighted to have all of you here and to learn from your esteemed experience. So I'll start with Mwangi. So as an expert who has advised across financing models, if you were sitting with the Ministry of Finance today, what advice would you give them on how to finance medical education? And what model or mix of models would you recommend?
Thanks for that question. It's a pleasure to be here with all of you today. Thanks for having me. So if I was advising a finance minister, I would first say to stop sort of fixating on which model or which mix of models, and to really ask 4 design questions about whatever mix of models you currently have. So 4 questions are, to ask of every financing stream, the 3 that you mentioned, are: have you costed it? Who owns a recurring bill in year 10? Is it tied to real jobs for health workers? And who holds the off switch? Is it you or is it the donor? So first thing, we have to acknowledge the fiscal crisis that a lot of these national treasuries are in. The median African government spends over 12% of its revenue on interest payments, and by one count, 32 African countries spend more on debt than they do on health. So you can imagine what a small share of that is, funding health worker training. After last year's aid withdrawal, bills that used to be taken care of by donors, are now falling on these national treasuries. Most of that wasn't health worker training, as you all know, but it's displaced funding that could have gone to that. So there are second-order effects there. So on the 3 models, on the public financing, the state obviously is the right lead payer because it's the one that really captures the full benefits of a trained doctor, which is a working health system. So I tell the minister to do 3 specific things. 1, cost the product before you fund it. There was a study, in Kenya, I believe PASCAR published it last year, that showed that for many medical schools, I think most medical schools hadn't empirically costed their own medical program. So that's really important. It really is a fee for the most expensive program in the system. And in one dean's words, they were, a lot of these numbers they were using were estimates. So you can't finance what you haven't priced. That's the first thing. And then two, looking into using potentially earmarked levies, with honest limits. So, designs like Nigeria's TET fund, which is a fund for tertiary education that's funded through a 2% tax on corporate profits. Ghana has the GET fund that does something similar with VAT. So the lesson here is that money embedded in a statute is more durable than money that it's more likely to survive a budget cycle than money that is not. So that's another thing. So these kinds of levies can be used for things like building labs and libraries, but they don't necessarily pay next year's salaries, and politics can still lead them to be capped. Another thing, looking at income contingent loans, there are models where government pays tuition up front and graduates repay through the tax system once they earn above a certain threshold. The evidence there is decent. The caveat for our context really is that it needs a tax administration that can actually collect, and it leaks when doctors emigrate in large numbers. So, and then on donor financing, like you said, it's fast and it can get results, but the sustainability problem is real, and we've seen it in the last few years. The MEPI program that you mentioned, it was a $130 million program. America funded, I believe it ended in 2015. And one of the things that it did was work to strengthen medical schools in 12 countries. And, it did things like building, digital infrastructure that really lasted. And then some of the things that it funded, went away after the funding left. There were research programs that ended very shortly after the funding ended. So for the minister, I would advise thinking about donor funding, especially when it's time boxed and when it buys assets, rather than simply paying salaries and covering recurring expenses. And when it comes with a costed handover plan, where where you have a plan for who's going to take on that bill once the funding expires. So that's I think I can stop there.
Thank you very much. So 3 advice: costed, earmarked levies, and income contingent loans. So I have maybe one follow-up. I think we heard Dr. James mentioning there are nearly 1 million unemployed health workers that have been trained. So if you were having that conversation, where would you tell the minister to put the next available dollar in?
Yeah, those numbers they're quite interesting. It seems like a paradox. You have 1 million unemployed health workers. That's obviously, inclusive of doctors. It includes a lot of non-medical doctors, alongside 5.85 million shortage. So I think, again, my caveat is going to be that different countries are going to need, they're going to have different best uses for that next available dollar, that marginal dollar. But I think in many cases, that next dollar needs to go to a post. And by that, I mean a funded job. So, and not necessarily to a new training spot. So let me explain why. So if you read the two numbers together, those numbers, I believe, come from the WHO State of the Workforce report from this year in May. And, it showed 1 million unemployed health workers and about 5.85 million. And the 5.85 million is a needs-based shortage. And it's what our populations require to be healthy. And the unemployment number reflects a demand-based reality that's obviously related to the fiscal crisis that we're in. So we're short of doctors, but we're also long on unemployed doctors at the same time. Because in many countries, the main constraint is no longer training. I think the continent produces over 325,000 health workers every year. Obviously, we would love to do more, but the constraint in many places is often funded posts at the end of the pipeline. So this paradox, it's very interesting. And why does it exist? The wage bill, in many places it's capped or frozen in much of the region. So that's gonna be a real constraint. Ministries who have paid to hire trained workers can't actually legally hire them in many cases. And then the next is, bottleneck stages. In Kenya, I believe we had a medical strike in 2024 when we had over 1,000 health workers, medical graduates, who were not posted because the government couldn't fund internships. So, the doctors went on strike for 56 days. And, it's a real problem because a graduate who can't do the internship can't get licensed, and the pipeline stalls, and then we're not able to really capture the benefits. As you said, the public, for the most part, pays for these or subsidizes these programs. So that's really important. And then obviously the aid shock again made things worse. And when American funding collapsed last year, we had in some countries, and I think in South Africa, over 8,000 health workers were left without a job, and in other places it was in the tens of thousands. So that's a big part of it. And we have double leakage really. We have doctors going abroad, and we're losing the benefits in that regard. And then we also have doctors who are we're also losing the benefits at home, with doctors being unemployed at home. So. Yeah, and then I will say, in terms of the hierarchy of what the next dollar should do, first I would say fund posts. So it often is the fastest return in health financing. The training is already paid for, and having a job makes it really pay off. The WHO has actually costed this, so absorbing every unemployed health worker would take about $3.40 per person per year, and would cut the projected shortage from 5.85 million to about 5.1 million by the year 2030. And then, funding bottlenecks is also really important. Internships and residencies, they are cheaper relative to full training, and they unblock people that we've already, whose medical education we've already funded. And we really need to view the post-medical school experience as a part of the training of doctors, and so it's a really core part of financing health worker training, of course. And then when it comes to funding new training, let's look for opportunities where a post can be guaranteed. So I know Thailand has a rural doctor program that worked in part for this reason, where every bonded graduate had a funded job waiting for them. Obviously, it's easier said than done. I believe South Africa had a similar bursary scheme, and it was a bit less successful because many beneficiaries had to default. And then fourth, and this is the cheapest, is funding the data. So unit costs, labor market tracking, so that ministers can actually allocate on rigorous empirical evidence as opposed to estimates. Really. So yeah, training and posts, those job posts, they're complements. They're not substitutes. And I'm just speaking about the marginal dollar. Of course, training health workers is extremely important, as you all know as deans. So yeah, thanks.
Thank you very much, Mwangi. I think these are very important statistics, particularly $3 per person will help us absorb all the health workforce. So next I'll go to you, Stella. COSEXA trains surgical specialists across 24 countries with a financing model that combines examination fees, donor support, hospital accreditation. So it would be great to learn from you what the model actually looks like in practice. And as a COSEXA, how are you addressing the burden of cost of training medical education? Over to you.
Thank you. Good morning, everyone. Please allow me to first tell people what COSEXA is for them to understand the concept of our model of training and the cost that is incurred. COSEXA is a surgical training college operating in 24 African countries across 152 training sites, and these are hospitals in the region. It offers an on-the-job surgical training program to 12 surgical specialties with 152 program directors. And these program directors are in each training hospital, which is a training site, and more than 1,000 trainers across the region. The theme of our session, who pays the cost of educating medical professionals, resonates well with COSEXA. I think I would change and pose a fundamental question of what is the cost of not paying to train these doctors. You and I know. So the price of underinvestment in medical education should not only be measured by the budget, the training fees, tuition, but in lives lost, the health inequalities, the economic system failures, and the health system failures as well. We also have to look at the doctor shortages, but also brain drain. So in this regard, COSEXA model takes into account several other factors that are the real costs of training. And these include the infrastructure and equipment in hospitals, faculty time, clinical exposure, technology, accreditation systems, continuous quality assurance, and CPD. At COSEXA, we've learned that the cost of training a medical professional is not borne by one institution, one government, one donor. It is a shared responsibility to invest in a holistic program for health systems training to ensure that we have quality medical professionals. And in this case, everyone, all stakeholders, the players in the health sector must co-own the responsibility of training these health professionals that they require in Africa. So as COSEXA, it's an ecosystem that has transformed the college, not only as a training institution, but a platform for regional workforce investment. And our model is built on factors that the cost of training is borne by the government, by the universities and professional colleges, by the students themselves, COSEXA as an institution, and collaboration partners. And this is how. The government support COSEXA through scholarships, and these are through ministries of health. And that's what the previous colleague talked about. That's public funding. Also, the government supports COSEXA training through recognition of its trainees across the region. Also, resident deployment. The fact that our training model is a training on the job, in most cases, and our statistics also tells it, the retention level of our trainees is 98%. Because these people are already employed in these hospitals, trained with these hospitals. It's under few circumstances that people have to leave their training sites for other jobs. But the good advantage with that, most of them remain within the region. In addition to government, we have universities. The universities we collaborate with and professional colleges support our trainees through research, examination support, curriculum development, and faculty participation. I'll give an example of the University of Global Health Equity. Just a month ago, we got a group of 13 faculty members that trained COSEXA residents in research. It was a five-day workshop, but we got free of charge the faculty members from the University of Global Health Equity to support our residents. We also partner with other colleges here, Colleges of Medicine of South Africa, West African College of Surgeons. They support us through examinations. So when I say it's a holistic kind of support, not necessarily money, but in kind. So if we are to look at the cost of training, let us not only look at the tuition or training fees. From partners, we get funding from our collaboration partners. They provide scholarships and cover training fees. That's registration, examination, graduation, and stipends. We all understand that the cost of training in Africa is high. But our partners are very generous enough to support us in that area. We have one of our partners here, Smile Train, who are doing that job generously, and so far we've increased numbers because of their support. They not only support us in that, but they also enhance the capacity of our trainees through exchange programs, training of trainers, and post-fellowship. In addition to that, they also provide catalytic investment. For example, the headlights, the surgical loops, and any other infrastructure. So when we talk of the cost of training, we look at different aspects that surround that training. COSECSA as an institution, it's a recipient of these residents, but also provides support. And this is through harmonization of curriculum across the board, accreditation of all training sites in the African region, especially in the hospitals where we train, faculty development, and accessible e-learning platforms. We have an e-learning platform called School for Surgeons, accessed by our trainees, fellows, trainers across the board. And our online resources are under the WHO Global Surgery Hub. It's called Surge Hub, which is accessed by everyone globally. I remember, I think there's a doctor who talked about providing online resources and sharing data across the board, which COSECSA is already doing. I think it was under the theme of being in 2024 or 2034, something of the sort, 2040. So I will say that instead of each country working in silos, training these people that will be in fragile situations and environments, if a region came together to have harmonized standards, coordinated program, accreditation systems, it's a regional responsibility of training these medical doctors. In terms of how we are addressing it, I'll talk about training institutions. We enhance the capacity of our training institutions, the faculty capacity, accreditation systems and regional standards, examination systems, surgical training systems. We also look at virtual learning platforms, online academic sessions. We run sessions every 3 months in a year, and each session we have 500 participants. This is not only in COSECSA countries, but all countries. We do also have remote mentorship, virtual faculty engagement, and data-driven monitoring. So I'll end there by saying that shared responsibility of covering the cost of training is the solution to Africa medical professional education. Thank you.
Thank you very much for that, Stella. And I think you've highlighted shared responsibility. I have one follow-up for you. So you mentioned that not paying the cost of medical education is more pricier. So what strategic mechanism or approaches can be put in place to ensure equitable health education and training and distribution in short? Thank you.
Thank you. At COSECSA, we believe in training Africans in the African context with African patients, African hospitals, by Africans, supported by external expertise, which is the solution and mechanism. And our mechanism is affordable training. If you compare the cost of training a COSECSA surgical resident vis-a-vis the cost of training in other education systems, ours is very affordable. Then training on home ground. We also accredit hospitals in rural, urban, and semi-urban. And it also ensures that our residents do not move from one home to the other. They are trained in their home countries. We also provide for mutual recognition of our trainees. A COSEXA trainee who has undertaken our fellowship program can work in Kenya, can work in Tanzania, can work in Zambia, can work in Zimbabwe. So that's cross-border migration, but within Africa. We are not selling or exporting our expertise. Regional balance scholarships. With our donor partners, each time they come, we evaluate which countries are in dire need, and we consider those most than those that are capable. We also support cost-effective technology. You will agree with me that technology does not replace teachers, but it multiplies teachers and enhances the reach of many teachers. Establishing centers of excellence. We ensure that our trainees are exchanged in different training sites that are of high quality, more advanced in different expertise, especially we've always exchanged our trainees from Rwanda, Tanzania, Uganda, Kenya, to here, Ethiopia, where their expertise in cleft surgery is quite high. Harmonization of the curriculum. I think it's a mechanism that also provides for not having different fragile systems and curricula, but having one that is going to be accommodated by everyone. And I think all of us in this room should work towards that. Let's not have different standards, different guidelines, different regulations, but have a holistic system that cuts across all board. Faculty development and accreditation, those I've already mentioned. So COSEXA's experience provides a different approach. It's a financing ecosystem that produces specialists that focus on training institutions, faculty development, health system strengthening. Thank you.
Thank you very much. Africans for Africa, trained at home with mutual recognition. I think those are great sentiments. So next I'll go to Melissa. Melissa, I know ELMA invests in health workforce development across Africa, including maternal-enabled health and pediatric workforce programs. As a private philanthropy, how do you ensure that sustainability is built into your investments so that the impact is sustained?
Thanks for that question. Good morning, everyone. At ELMA, we've been investing in building the health workforce on the continent for the past 20 years, and we've had a lot of learning along the way that's informed how we think about addressing health workforce shortages in a sustainable way. So today I'm just going to talk about two ways, primarily at the training institution level, because I know our audience is primarily deans. And so the first is investing in smart scholarship models, not just looking to address a shortage, but looking to use a scholarship to also impact distribution and retention. And the second is supporting the development of or strengthening high-quality, sustainable training programs at African training institutions. And I'll give a practical example of each of these. So one example of how we've supported smart scholarships is through the African Pediatric Fellowship Program. So this is a South-to-South model that was designed to respond to the shortage of child health specialists on the continent, but also to address the issue of brain drain, where the majority of specialists that were training in the US or the UK failed to return to their home countries. So the African Pediatric Fellowship Program was launched at the University of Cape Town in 2008 and then was later expanded to 2 additional South African universities, University of KwaZulu-Natal and University of Witwatersrand, in response to the overwhelming demand. And now they're the leading provider of specialist and subspecialist training for African child health professionals. So the way that it works is that South African universities establish partnerships with peer universities and associated teaching hospitals, and they identify priority areas that they want to improve or expand pediatric clinical services and the associated training requirements for those. And then each institution selects the fellows, pays their salary while they're in South Africa, and ensures positions for them on their return. So through our support along with other donors, we've been able to support 345 pediatricians, pediatric subspecialists, and pediatric nurses from 21 African countries with a very high retention rate in their home countries. And many of these specialists are returning as the first subspecialists in that country, like the first neonatologist in Zambia. And so we've seen that they return not just to improve clinical services, but that they also change policy and practice, and they train others, they advocate for resources, and then conduct research. And we've seen that this impact ripples significantly. The other way that we've thought about sustainability is building the capacity of African training institutions. And this is more about cultivating long-term partnerships rather than funding projects. And understanding the long-term vision of the university and the bottlenecks that they need to overcome to get there. So one example of this is our partnership with the Ministry of Health in Rwanda and the University of Rwanda. Over the past 5 years, we've been partnering where they have a vision for the pediatrics residency program to be sustainable and to not rely on external faculty in the long term. And so they've identified this is the local faculty that we need to be able to be sustainable, and then we've been supporting them to send Rwandan pediatricians to get their subspecialty training and temporary external faculty to support while they're gone until they can return and then build the sustainability of their training program. We've also supported training institutions that want to undertake the transition to competency-based education and introducing simulation as a pedagogy and not just the procurement of equipment. So I'd say there's no silver bullet in addressing sustainability, but these are a few examples of the learning that we've had along the way and how we try to approach partnerships so that investments can be more sustainable.
Thank you very much. Investing in smart scholarship models and strengthening African training institutions. I think these are great examples. I maybe want to follow up in terms of what do you think would incentivize or attract more investment from private philanthropy in medical education, as we're hearing a lot of constraints in fiscal systems and also some shifts globally? Over.
The big question, how do we get the money? You know, there's a big disconnect, I think, between African universities and private philanthropy, but I think there's so much untapped potential there. And so one of the major challenges that I see on the continent that we've heard, you know, this morning and over the past few days is we often see this complete disconnect between supply and demand of the health workforce at the national level. Between how many and what types of graduates are produced from training institutions, and then what a country needs and is hiring for in the public service. And so this results in labor market failures and this dual crisis that we've talked about this morning of a health workforce shortage alongside high unemployment. And you know, it's this waste of human and financial resources is just devastating in a context where we have fiscal space is continuing to shrink. You know, and I think this is a product of a system that doesn't have data integration and visibility of supply and demand, and it doesn't have the proper incentives for coordination of key stakeholders in the health workforce ecosystem that are primarily divided between training and practice. And so really the bottom line is that private philanthropy really wants to have a return on investment. And so we need to do a better job of thinking strategically and then selling medical education as an investment with a high return. And I think there's two main components to this. The first is a commitment to high quality education and evidence-based pedagogy to ensure that graduates not just leave university with a piece of paper, but that they're equipped with the potential, those competencies that they're going to save lives. And the second one, I think, is a challenge, but I think it's true that universities need to show an increased interest, a vested interest in the full pathway to impact, and not accepting the traditional mandate that ends with graduation. You know, we know that training institutions don't have the power to hire healthcare workers once they graduate, but they can take a vested interest in what happens after graduation and cultivate partnerships with the Ministry of Health, with professional associations, with regulatory bodies, and other key stakeholders so that we can ensure that pathway to impact after graduation through absorption, performance, and retention. And the third component, I think, is we need to commit to measuring impact of the health workforce, because we've done a really poor job, I think, of selling how impactful they can be. So one example I'd like to share of how we've seen this play out practically is in Kenya. We've worked with 3 universities and 2 nurse training institutes to come together with the Kenyan Pediatric Association and CHAI as an NGO to support the expansion of fellowship training, both intake in fellowships, but also the starting of new fellowship training in pediatric specialization. But they've come together with different mandates and interests to think about a strategic plan of how do we train and deploy these specialized healthcare workers so that they're going to have an impact. So they sit and think about working with the Council of Governors to identify where do we need advanced neonatal care, then working with the counties to release them, and then train in teams neonatologists and neonatal nurses to be deployed back to those counties as teams, and for it to be aligned with where there's been equipment investment through programs like NEST, so that neonatologists and neonatal nurses can then practice to their full capacity. So this worked because partners were willing to come together despite their different mandates and interests to ensure that there would be a pathway to impact. And so I think what private philanthropy would be really interested in, if I can speak on behalf of a very diverse group of people, is training institutions that are willing to think out of the box, think strategically, and cultivate partnerships so that they can take a vested interest in graduates' impact after they leave the institution. Thanks.
Thank you very much. So we need to sell medical education as an investment with high return. I think that is a very important message. Thank you so much. So next we'll go to Prof. Philip. Prof. Philip, you've been a Vice Chancellor at 2 universities and helped set up medical schools in both donor-supported and government-backed contexts. So from your experience, what actually makes medical education financially sustainable?
No, thank you very much. The longer I stay in universities, the fewer answers I have, really. But we've got to where we are, haven't we? In some sense, by hook or by crook, often making do and mending. But can we go on in the way that we have been functioning? Probably not. And that's why we've got this panel today. I wanted to just focus some of my responses around 4 I's. Imagination, capturing imagination, investing in faculty and investing in ourselves, interest from different financing models, including the interest that we might share from endowments, and interdisciplinarity, because I think we're missing something in that space. I'm going to say 2 things that are almost contrary. And the first thing is to invoke the words of a hymn, "Tell out my soul." We need to speak about our spirit. We need to speak about our mission. We need to tell the world about the things that we're doing. Yesterday I sat down with the dean from Eduardo Mondlane University in Maputo, and we shared some of our successes, some of our labors, some of the amazing things going on in our universities. And we had this beautiful appreciation of just the magnitude of impact and change that we're making. But we seldom find ways to share that with the rest of the world, because we have to take the rest of the world along with us as we build trust. And the contrary thing is that while we're telling out our souls, speaking about the spirit that moves us as institutions, training people for lives of service, we also need to humble ourselves. And we need to humble ourselves, I believe, by speaking to our third mission. And universities often pride themselves on their first mission to teach, to educate, their second mission to research, and our third mission, which is to do some community service. But actually, if we elevate that third mission of community service and work through that, it tells us everything we need to do, everything we need to know about teaching, learning, assessment, and research. We have to capture the imaginations of people who we sit in meetings with year after year, month after month, week after week, being told what we don't do properly and being told that we're falling short and we need to pull increasingly on resources that we don't have. We need to invest in our faculty. We need to invest in our faculty so our faculty can invest in us. When I say faculty, I also want to talk about the entire ecosystem in our schools, because our students very rapidly, within 2 or 3 years, become our colleagues. And the truth is, the reality is that our students contribute indirectly to patient care in the early years of training and substantially and directly to patient care in the later years of their training, working alongside faculty who often spend countless hours working away from their families and their main family homes in service of the people that come to our hospitals and we often call patients. But we need to invest in one another in a way that we don't always witness. I want to caricature in the most horrible of ways our regulators and sometimes our relationship with our regulators. You see, in my university we have, and I'm going to use the term, and I apologize because I don't like the term, but we have a state-of-the-art laboratory that serves every part of BMS, physiology, biochemistry, pharmacology. And we have this amazing, incredible team of laboratory technicians that operate that one singular, unitary laboratory. And when the regulators come and say, you know, Professor, that's not good enough. You've got to have a laboratory for each of those BMS sciences, and you've got to have a different team for each of those sciences. And I say, and you're talking about cost efficiency, you're talking about cost effectiveness, you're talking about cost minimization, you're talking about cost benefit. Are you? When we give access to our students to digital resources, access to the medical school libraries in Harvard and Stanford, that's a true story, by the way. And the regulators come and they say, but you see, we have to count the numbers of textbooks on your shelves. The fact that a medical textbook is 3 years out of date by the time it's published. The fact that we have 60 copies of the same textbook that is out of date, but we count them. You see, we have to invest together. And together we are stronger, because in this room, regulators and educators, together we are medical education or health professions education. We talked about return on investment. You see, society wants to see a return on investment for us. And so our regulators become the most progressive and the most developmental of all agencies I could ever lean on, rely on, and call on. Tade, I see you. Tade, I see you. You're nodding, my dear brother. We have to find ways to fund medical education. And my third eye is that of interest, because we increasingly have to look at the interest from investment, from endowments, from annuities, different ways. And you see, we can only attract those investments if we capture the imaginations of people, if we invest in our faculty and the people that we serve. And it's a cyclical thing based on trust, based on accountability. But we often don't know the full economic costs of delivering our curricula. Whether you use an ABC activities-based costing or a full economic costing, we don't actually know what the true cost is of educating a student. And most of the education of medical and health profession students takes place outside universities, in that most exquisite of places where we have the most intimate and beautiful encounters with people in the communities in which they live. That's where the learning takes place. And learning, of course, always has primacy over teaching. In Rwanda, when I was at the University of Rwanda, we worked with the Ministry of Finance and Economic Planning on a full economic costing model. And we determined that the true cost of educating a medical student was at least 3 times the amount that most families could afford to pay in tuition fees and most treasuries could contribute. We need to have those figures, we need to have those costs at our fingertips. And that's why we need to speak to our regulators about teaching as a multi-faculty group. And I come to my fourth eye, which is the eye of interdisciplinarity. You see, if we continue to train medical doctors for specialties without training, for example, a cadre of nurses in the same specialty, we will not be able to give society the return on investment that they require. We have to, our next neonatal training program, our next family medicine training program has to have nurses and doctors training side by side, journeying side by side, being taught in the early years of the undergraduate medical curriculum by physiotherapists. Believe it or not, physiotherapists teaching anatomy to medical students. Who ever heard of such a stupid thing? Of nurses teaching undergraduate medical students. What utter nonsense. Of healthcare workers who I cannot get recognized as faculty because, you know, they work with the most intense form of expertise and knowledge and intelligence that I could never, ever have unless I spent my entire lives living embedded in those communities. But they do not have all the letters after their names that I have. So they cannot be recognized as teachers. What total and utter nonsense. We have to capture people's imaginations. We have to invest in our people. We have to work on different funding models that allows us to realize the true value of return on investment. And we have to capture interdisciplinarity if we're ever going to create an affordable form of medical education. With the greatest humility, let us tell out our souls.
Thank you very much, Prof. Imagination, investing, interest, and interdisciplinary. Apologies, everyone. Because of the constraint in time, we will not be taking any questions from the audience, but our panelists are around in the coffee break, so I invite you to corner them and ask them relevant questions. So thank you so much, and we'll end here.
All right, ladies and gentlemen, before you leave, we have a quick announcement. Before you leave. We have made some time adjustments to allow us enough time to make the city tour in the afternoon. So coffee break will be up to 10:30. The breakout then will take place from 10:30 to 11:30. Lunch, we'll have lunch starting from 11:30 a.m. to 12:30 p.m. And during lunch, make sure that you wear comfortable clothes, because after the 2 afternoon sessions we're going to go directly to the city tour. So during lunch, you quickly have your lunch, then you wear comfortable clothes and shoes, and then we'll have our final plenary from 12:30 to 1:30 p.m. and our closing ceremony from 1:30 to 2:30 p.m. And then from 2:30 p.m. we can have our city tour. So please enjoy your coffee break and be mindful of time, and we wish you a lovely third day.
ብቻ አይደለም የሚጠበቅበት ታካሚን ማከም ብቻ አይደለም
You are really showing us the real brotherhood, the real Africa spirit.
ጎረቤት ጤነኛ ካልሆነ የኛም ጤና ዋስትና አይኖርም።
ኢትዮጵያ ለሌሎች አፍሪካ ሀገራት የምታካፍለው ትልቁና ዋነኛው ነገር የሬዚደንሲ ፕሮግራማችን ነው።
የኢትዮጵያ የሬዚደንሲ ማቺንግ ፕሮግራም ከመጀመሩ በፊት በሀገራችን የስፔሻሊስት ሐኪሞች ቁጥር ከ1500 የሚበልጥ አልነበረም። በመሆኑም እንደ አውሮፓውያን አቆጣጠር በ2017 ፕሮግራሙ በሀገር አቀፍ ደረጃ የተጀመረው የስፔሻሊስት ሐኪሞችን ቁጥር ለማሳደግ በማለም ነው። በሂደት የማሰልጠን አቅም ሲያድግ ደግሞ ለአጎራባች ሀገራት ሐኪሞች እድል በማመቻቸት ተጠቃሚ እንዲሆኑ ተደርጓል።
በመንግስት ከ37 በላይ የሚሆኑ ዩኒቨርሲቲዎች ላይ የሕክምና ትምህርት መስጠት ተችሏል ማለት ነው። በግል ደግሞ ወደ 9 የሚሆኑ የጤና ትምህርት ተቋማት በተለይ ዩኒቨርሲቲዎች የምንላቸው የጤና ትምህርት ተቋማትና ትምህርቱ እየተሰጠ ይገኛል ማለት ነው። ይሄ እንደ ሀገር ትልቅ ስኬት ነው። ኢትዮጵያ ለሌሎች አፍሪካ ሀገራት የምታካፍለው ትልቁና ዋነኛው ነገር የሬዚደንሲ ፕሮግራማችን ነው። ይሄ የሬዚደንሲ ፕሮግራማችን ትምህርቱን እንግዲህ የዛሬ 10 ዓመት ስንጀምር አጠቃላይ ኢትዮጵያ በሰብ ስፔሻሊቲም ደረጃ ስፔሻሊስትም የነበራት ማለት ነው። አጠቃላይ 1500 አካባቢ ነበረ በቁጥር የሚሆነው። ባለፉት 10 ዓመታት ግን 10000 የሚሆኑ በየአመቱ በአማካይ 1000 የሚሆኑ የስፔሻሊስቶችንም ሰብ ስፔሻሊስቶችንም ፌሎሺፕንም እንግዲህ ቁጥር ጥምርታ መጨመር ተችሏል።
ጤና ያው ድንበር ተሻጋሪ ነው። ጎረቤት ጤነኛ ካልሆነ የኛም ጤና ዋስትና አይኖርምና ስለዚህ ጎረቤት ሀገራት ካለ አጠቃላይ የጤና ሁኔታ የኛንም ሀገር የጤና ሁኔታ አፌክት ማድረጉ አይቀርም። ከዛ አንፃር በተለይ እነዚህ ጎረቤት ሀገሮችን ያላቸውን የወርክ ፎርስ ካፓሲቲ ለመደገፍ ብዙ ርቀት ተኪዷል።
እስካሁን 600 የሚሆኑ ሐኪሞች በተለያየ የሕክምና ስፔሻሊቲ ስልጠና ኢትዮጵያ መጥተው እንዲሰለጥኑ ማድረግ ተችሏል። ከ600 ውስጥ ከ100 ያላነሱት ስልጠናቸውን አጠናቀው ሀገራቸው ተመልሰው ህብረተሰባቸውን ማገልገል ጀምረዋል። አሁን ላይ ደግሞ እንደዚሁ ከ500 የማያንሱ በስልጠና ላይ የሚገኙ ሐኪሞች ይኖራሉ አሉ በተለያዩ የሕክምና ስፔሻሊቲ ስልጠና።
Over 100 Rwandan doctors have benefited from this remarkable.
ከመቶ በላይ የሩዋንዳ ሐኪሞች ፕሮግራሙ ተጠቃሚ ሆነዋል። በኢትዮጵያና በሩዋንዳ መካከል ያለው ወዳጅነት ለሰው ትብብር ተምሳሌት የሚሆን ነው። ከሬዚደንሲ ስልጠናም ያለፈ ነው። በዚህ ትብብር ሁለቱም ሀገራት በቀጣይ ትውልድ የጤና ባለሙያዎችን የአፍሪካን የጋራ ራዕይ ለማሳካትና በጤና ዘርፍ ሉዓላዊነትን ለማስከበር ኢንቨስት እያደረጉ ነው።
We used not to have many types of specialty but currently with this
በሀገራችን የስፔሻሊቲ አገልግሎቶች አልነበሩም። አሁን ግን ከመቶ በላይ በተለያዩ ሙያዎች እያገለገሉ ነው። አሁን ወረርሽኝ እንኳን ቢመጣ በሰለጠነ የሰው ኃይል ወደ ጎረቤት ሀገራት ሳይዛመት መቆጣጠር እንችላለን።
በተበጣጠሰ መልኩ ይሰጥ የነበረውን የሬዚደንሲ ስልጠና ወደ ማዕከል በማምጣት የሚፈለገውን የሰው ኃይል ለማብቃት እየተሰራ ያለው የኢትዮጵያ የሬዚደንሲ ማቺንግ ፕሮግራም በመረጃ ላይ ተመስርቶ ለመምራት የሚያስችለው የሰው ኃይል ስትራቴጂና ኢንቨስትመንት እቅድ፣ የቅጥር ዕድል ማስፋት፣ ፍትሃዊ የባለሙያዎች ስርጭትን ማስጠበቅ እንዲሁም የጤና ስርዓት አመራርን ያካተተው አዲሱ የሕክምና ትምህርት ካሪኩለም ከተገኙ ውጤቶች መካከል ተጠቃሽ ናቸው።
ቅጥርን በተመለከተ እንደ አንድ ችግር የሚገጥመን ስለነበረ
esteemed colleagues, kindly note that the breakout sessions are starting at 10:30, so quickly grab your coffees and go to your breakout rooms directly. We're trying to finish today early to allow enough time for visiting Addis. So make sure to proceed to quickly grab your coffees and then proceed to your breakout rooms. And then inside the breakout rooms, you can finish up your coffees and snacks in there.
ሬዚደንስ ብሔራዊ ስፔሻሊቲ ፕሮግራም ደግሞ ሬዚደንስ ማቺንግ የምንለው ይሄ ፕሮግራም ጥቂት ተቋማት ነበር የሚሰጡት። ይህንን በልዩ ሁኔታ በማዕከል ወደ ማኔጅመንት በማምጣት በአመት ከ1200 ከ300 ከ1300 በላይ ሐኪሞችን በተለያዩ ተቋማት በተለያዩ ስፔሻሊቲ አይነቶች ማሰልጠን ተችሏልና ይሄ አንዱ ትልቅ ስኬት አድርገን የምናየው። ሌላው የሄልዝ ሌበር ማርኬት አናሊሲስ የሚባል ይሄ የሌበር ማርኬት አናሊሲስ ትልቅ ጥናት ነው። ወርክፎርስ ከፕሮዳክሽን ጀምሮ ስርዓት ውስጥ ገብቶ እስኪወጣ ድረስ ያለው አጠቃላይ በምን መልኩ መመራት መሄድ እንዳለበት ጥሩ ኤቪደንስ የሰጠ ነው። ያን ብቻ ሳይሆን ከዚህ ቀደም ባለሙያዎች ወደ ስራ የሚገቡባቸው አማራጮች ትንሽ ናቸው። ስለዚህ አዳዲስ ስርዓቶች እንደ ኦፊስ ፕራክቲስ የምንላቸው ሜዲካል ፕላዛ የምንላቸው አዲስ ስርዓቶችን መዘርጋት ይችላልና ይሄ አንዱ እንደ ስኬት የምናየው ነው።
ይሄ የጤና ስርዓት ተኮር ወይም በእንግሊዝኛው ሲስተም ኦሪየንትድ ሜዲካል ኤጁኬሽን ወይም ሲስተም ቤዝድ ሜዲካል ኤጁኬሽን የምንለው ከሕክምና ሳይንስ በተጨማሪ ወይም ከክሊኒካል ሳይንስ በተጨማሪ የጤና ስርዓት ሳይንስን ወይም ደግሞ ሄልዝ ሲስተም ሳይንስን እንደ አንድ ትልቅ የትምህርት አካል አድርጎ አቅፎ የያዘ የትምህርት ካሪኩለም ነው። እንግዲህ በተለምዶ የነበረው የሕክምና ትምህርት ካሪኩለም በጣም ትኩረት የሚሰጠው ለሕክምና ሳይንስ ነው። በሕክምና እውቀት ለሕክምና ችሎታና ክህሎት ላይ በጣም ትኩረት ይሰጣል። ከዚህም በተጨማሪ ደግሞ በታካሚዎችና በሐኪሞች መካከል ባለው ግንኙነት ላይ በጣም ትኩረት ያደርጋል እና የጤና ስርዓቱን የመዘንጋት ነገር ይታይበታል ማለት ነው። የቀድሞ ከዚህም በፊት ስንተገብረው የነበረው የሕክምና ካሪኩለም። ነገር ግን አንድ ሐኪም የትምህርት ጊዜውን ጨርሶ ተመርቆ ወደ ስራ ዓለም ሲገባ የሚጠበቅበት ታካሚን ማከም ብቻ አይደለም። ከዚህም በተጨማሪ ደግሞ የአንድን የሚጠበቅበት ታካሚን ማከም ብቻ አይደለም።
You are really showing us the real brotherhood, the real Africa spirit.